Next title will be maybe something can be overlapping with other talk when I look at the program. I will try to hurry up the content. So pulmonary arterial occlusion, this title I would like to focus on this ASO. So I handled this pulmonary artery aneurysm will be handled with other presenter. There must be different other reasons for this flow limitation by traumatic injury and embolic occlusion. And I handled this 5 or 6 just immediate before. So you have to, when you need to access here or from the AP or the PA or from the proximal to distal, should realize the location relatively from the vein side and where and the relationship between the muscular area and sometimes the adjacent branches. So this will be very helpful to save the pulmonary artery. So usually I'd like to give the smaller profile, 5 French short stretches for the pulmonary CTO, because the smaller profile good for hemostasis, and the straightforward shorter distance to give good support. So 5 French and the CT wiring, MP1 catheter, and 40 CT wiring with the good supporting catheter or the selective microcatheter. When I require this 18 CT wiring or the 14 CT wiring. So these are the series of my favorite 14 CT wiring, but pan-TR, including SFA, many patients could combine the distal SFADs together. So primarily, my favorite CT wiring for the pan-TR would be Connect Flex 12 gram. This is good because this cannot go outside of vessel. So hydrophilic and maintaining inside of the vascular space and will not perforate. So this is good. And Halbert, this is good shaft support. Same 12 gram, but this is a channel tracking and slide technique is better, but the Halbert shaft support is better. And this can push forward to the direction control, and the straightforward pushing force is better than the connector flex. So other tapered the Gaia PV and the more short course straight, really penetrating forward and penetrating focal calcium is good by the S-starter series. So BTK CT wiring is the key, and the smaller tip is important. The larger tip is very disturbed by the side branches. So sometimes CTO devices are very helpful in the short segment panitar CTO. So we have used people, but not useful in these days because CTO wiring is very good these days. Focal calcium in the diamond drill in the panitar focal calcium through pass was nice at the before. Viance catheter less strong than the diamond, but this is good. Like a manual rotabulation, this is kind of a distal SFA, not the panitar, but this is a good sample. Inside waiting this 14 wire manual rotabulation. Fast spin in one side that this can destroy this proximal cap and can go down. Then just to deliver the 14 wire to the balloon angioplasty and the DCB, then easily can recanalize. Same as in the panitar area. So this is good. And sometimes if you fail by the usual CT intraluminal or the retrograde, the subintimal tracking, then you can use to prevent the dissection extension. Then you can use this 3 different available in re-entry device in Korea. The APVIC is the most popular, but instead of the extensive use of this re-entry catheter, we are more prone to use in the retrograde or bidirectional approaches because isolation of the CTO segment in the panitar is very important not to induce the dissection extension to the BTK. Is saving avoiding the stent is important, and finally with the DCB. Plaque modification is very important in the ASO in the the pannulateral area. So many use in the real SFA with the focal calcium, cutting balloon angioplasty, and the scoring balloon with the vascular tract, and the directional atherectomy with the turbo hook, and rotational atherectomy with jet streaming, and the rotablation, and the rotarex, and this kind of atherectomy devices can be very helpful. So this simple DCB application after good balloon angioplasty is nicely can be done. However, the many of this ASO with the dense calcium is a problem. So you can see this kind of, we cannot shift it or we cannot neglect it. So this kind of situation, sometimes we need the supera stenting. When this kind of looks okay, but in the lateral projection, the dense calcium cannot overcome by this balloon angioplasty. That can be a real barrier. So that's why we need the cutting balloon angioplasty and this scoring balloon, and then even two-wire system is better than nothing. Then this mechanism action can be inflate balloon, focused force plaque modification can be achieved when we observe by the OCT observation. This is a sample of the vascular tract involving the distal SFA and the pannulateral area. This dense calcium in the focally. We can do just 18 CT wiring. This dense calcium, after crossing this 18 wire system, then the simple smaller balloon crossing, you can see that this another parallel wiring on the vascular tract, and this is a little bit not the NC balloon like semi-compliant balloon fashion. The higher the pressure, the balloon diameter can be increased. When your crack can be achieved, then good balloon response in this calcified area. And the BTK also, distal runoff must be important at the proximal disease resolution. And finalized with the DCB, then good result in this focal calcification of the plaque modification. The final angiography looks fine in the pannulateral. So this not only the scoring and the vascular tract, this encircling angioscope and the scoring catheter, chocolate, and the angioscope, atherectomy device, and the debulking by turbo, longitudinal atherectomy device, especially in this kind of bifurcation area in the distal tibial bifurcation involving the P3 zone. This is important to solve the debulking, avoiding the stenting in the pannulateral knee joint area. No stent zone, the so-called hook zone by the DCB is good. And rotablation is relatively smaller reference vessel in the pannulateral distal area, and the less dense calcified and the dense tissue by the rotarex. This is a sample of the rotarex. After rotarex, less dense tissue in the inside of a pannulateral ISL lesion, post-rotarex and additional atherectomy by the silver hawk, then we can do the DCB and the post-DCB good result. So this is a jet streaming. Jet streaming also less dense, less calcified area in the pannulateral is a good performance. So 4 different dimensions we can use this jet streaming in the pannulateral area. This case is a supera stented ISR involving the SFA and the pannulateral artery. Long SFA stented the CTO involving distal SFA and the pannulateral stented CTO. This is a supera stented CTO. Supera is not all good for the entire pannulateral area. So after crossing, many are the relative contra thinking that relative contraindication in the stented portion by the jet stream. But I feel that the jet stream is good for ISL lesion. So after 1.5, the loop angioplasty in the entire SFA and the free motion to the BTK, just a small ballooning after crossing the 18 wire, exchange to 16 wire, make a space by 2.5 millimeter and slowly jet streaming. This is a jet streaming slowly and make a space. This is like a debulking in the pamnital area. This is a good, useful debulking method. After simple jet, you can see the very good minimal luminal area can be achieved by the simple jet swimming alone. So after this, we can do the non-component ballooning, prolonged inflation, 2 to 3 minutes. Just a simple non-component ballooning, good result after then finalize the DCB with long DCB. Then final entropy can be done. Now, even long ISL region, then debulking plus by the debulking by the turbo, the jet stream plus DCB. Nice results can be achieved, even despite the long SFA plus the pamnital ISL. Sometimes this angiojet, the fresh, relatively organized area in the pamnital thrombotic, that is a previous case, so I will skip this. Angiojet that I shown this pamnital inflammatory syndrome. So this patient after angiojet, thrombectomy, this slowly thrombolytic levolytic power pulse mode after suction, the simple angiojet, good perfusion and result thrombosuction, then simple balloon angioplasty, further ballooning, thrombosuction, then you can see the very good post-thrombectomy injection. The interesting finding is after this, the plantar dose you have to test. So balloons for PTA, the mainly 18 system, we are using these two different range of DCB now from Boston, Lutonix, and the 3-5 system, two different DCB. These 4 DCB are available for the pamnital area. So DCB is useful after debulking. And the DES is not good for the pamnital even. We try to avoid. And this supera sometimes for the overcoming calcium. However, the supera is not always the solution for this kind of pamnital area. So my final slide, the EVT strategy in the SFA pamnital, especially pamnital, as I mentioned, we always should check for the external compression before doing implanting foreign body. So before stenting, always should consider the surgical option. So best ways to do before doing something is better to finalize with the DCB currently. So I prefer to any debulking and the plus plan modification plus the DCB would be my first option, my first recommendation. Leave nothing behind the strategy and make it clean and try to make the minimal luminal area bigger and try to reduce the recurrence and the BTK clearance and below ankle washout the best. So that the recurrence and eradication of the proximal disease then must be the best way to maintain the long-term patents in the pamnital area. Thank you for your attention.
Thank you, Dr. Ra.